Hey guys, my name is Shelby. I'm the scheduler medical records back in the health center. I'm going to go over the total body lift transfer competency. Now we have two different lifts we use. The first one I'll go over is a Hoyer. Now when you're using a Hoyer, you always use 2 staff members when operating the lift. Verify correct resident in order for lift. Gather supplies, proper sling, disposable wipes. You always want to inspect lift for damage and safety clips. Make sure the sling is not frayed, tangled, or something's ripping off. Make sure sling is the right size for the resident. Make sure you identify yourself and explain the procedure. Answer any questions the resident would have. If a resident has visitors, they need to remain outside of the room unless resident would like them present. Make sure you sanitize hands. Prior to the transfer, arrange the furniture in room to allow for safe handling movement. Make sure you provide privacy. Now we're going to transfer from the bed to the chair. Make sure you adjust height of the bed into a safe work zone. Use proper technique to place sling. Roll the resident onto his or her side. Place folded sling under resident. Top of sling should be at resident's knees. Now you're going to roll resident to the other side and position sling flat on the bed underneath the resident. You're going to open the legs of the base to the widest point. Wheel the lift to the bed. Position the lift with the spreader bar directly over the resident. Leave wheels unlocked. Lower the lift for sling attachment without striking the resident. Hook loops to spreader bar for appropriate transfer positioning. Raise resident while visualizing sling is in proper position, high enough to move the resident easily and safely. Leave legs to widest position while moving lift. If the legs must be narrowed when positioning it under the bed, you may do so, but must return them to the widest position as soon as safely possible. Gently move lift from bed. Avoid jerky movements. Maintain smooth, careful speed. Ensure resident is turned to face operator. Position resident over wheelchair. Lock wheelchair brakes only. Do not pull the lift by tugging on the resident. The handles on the sling are for guiding only. Carefully lower resident into the wheelchair. May gently pull on the sling handle while lowering to ensure the resident sits in a proper position. Once seated properly, remove sling from hooks. Carefully tuck out of sight. Ensure resident has collet and is comfortable. Wipe down lift with wipes. When you move a resident from the chair to the bed, here are the steps to do so. This is going to be just like the previous technique with a couple different procedures. You want to make sure that the resident folds arms over chest. Going to remove the wheelchair. Position the resident over the bed. The lift wheels are still to remain unlocked. Lower the resident onto center of bed. Remove the sling from hooks. Move the lift from the bed. Provide collet, ensure resident is comfortable, has privacy. Wipe down the lift with wipes. Each lift is equipped with an emergency stop button. If a lift fails to respond, quickly use the emergency release. When you use an emergency release, it will safely lower resident to the ground. The next lift we use is called an easy stand. An easy stand also requires the use of 2 staff members. The easy stand also gives the resident the opportunity to use their own weight bearing and participate in the transfer. First step is making sure you introduce yourself, explain the procedure. You'll want to check the lift and sling to make sure they are in good condition. Have the resident begin in a seated position on the edge of a bed or chair. You'll want to widen the lift legs with the lever and move the stand closer to the resident. Wrap the center of the sling around the resident's back so the upper straps come out under the resident's arms. Hook the straps onto the attachment points on the lift. Make sure to fasten the strap over the resident's upper belly area. Ask resident to grab onto the hand grips and put his or feet on the footplate of the lift, also using the black strap below to hook around the lower legs. Adjust the knee pads so they rest under the patient's kneecaps. Once everything is clipped, use the up button to raise the resident to a standing position. Wheel or pivot the resident to the surface the resident is being transferred to, such as wheelchair, bed, or chair. Make sure the surface you are using is locked in place before seating the resident. Once resident is seated, unstrap all the clips and have resident lift feet. Make sure to always wipe off the lifts with the wipes provided. Now we are going to go over how to ambulate with gait belt. We're going to ambulate a resident from the bed to the chair. First, you're going to identify self by name, identify the resident, wash hands. Explain the procedure to the resident, speak clearly, slowly, and directly. Maintain face-to-face contact. Provide privacy for the resident. Adjust bed to lowest position so resident's feet are flat on the floor. Make sure the bed wheels are locked. You're going to put on non-skid footwear for the resident. Stand in front of the resident. Stand with feet shoulder width apart. Bend knees and keep your back straight. You're going to place gait belt around the resident's waist. Check to make sure that the skin is not caught under the belt. Grasp the belt securely on both sides with hands in an upward position. On the count of 3, with hands grasping the gait belt, moving upward, help resident stand. Once resident is standing, tighten the gait belt. Walk slightly behind and to one side of the resident for full distance with 2 fingers grasping the gait belt in the back. If a resident has a weaker side, stand on the weaker side. Ask resident to look forward, not down at floor during ambulation. After ambulation, remove the gait belt, make resident comfortable, and remove the footwear. Make sure you leave the bed in the lowest position. Leave call light within resident reach and wash hands. Now we're going to go over care plans. What is a care plan? A care plan is a nursing document that identifies a patient's needs. The purpose of a care plan is to document the patient's needs and wants, as well as nursing interventions. As part of the patient's health record, the care plan is to establish continuity of care. A care plan helps nurses and other team members organize aspects of patient care. Care plans are structured as a 5-step framework: assessment, diagnosis, outcomes, and planning, implementation, and evaluation. Care plans are updated daily and need to be a part of your everyday uniform. The next topic we're going to go over is catheter care and how we empty a catheter bag. First, you're going to wash hands, apply appropriate PPE, gather all the right supplies. You're going to inform the resident of the procedure. Next, you're going to locate valve on catheter bag and set the graduate underneath. You're going to twist valve to empty contents into graduate. Close the valve as soon as bag is drained. Then you're going to record amount of urine recovered. Use an alcohol wipe to clean drain port on catheter bag. Empty contents of graduate into toilet. Clean the graduate with clean water from a clean graduate using the toilet for waste. Store clean graduate in IPP pouch in shared rooms. Doff PPE into trash receptacle. Then you're going to wash hands and take the trash with you. Make sure the catheter bag isn't twisted or the catheter tube may not drain properly. If the resident is brought out of their room, the bag needs to be covered at all times.
We're going to be going through perineal peri-care. And essentially you want to have what you need ahead of time. Most of it is in the room. Always knock and gain permission to enter the resident's room. Make sure you're sanitizing your hands before you go in or washing your hands. Gloving, getting what you need. If the resident does refuse cares at this time, always notify your charge nurse. And then if there's visitors in the room as well, ask them to wait outside until the procedure's finished. If the blinds are open, make sure you shut the blinds for privacy. And then make sure that you've got a barrier for the bed. So you can use the trash can liner on the bed. If you have 2 people, you can have a clean person and a dirty person. But do not throw anything on the floor. And do not put your disposable items and your soiled linens together. Put them in separate plastic bags. Once your gloved hand has touched something soiled, it cannot touch something clean. So if you're the dirty person and you've touched an old Depends or the garbage can or a used trash bag, you cannot get a fresh wipe out of the container for the other person with a dirty glove. You'll get dinged for that every time. Establish a clean work surface on the bed, sanitize your hands, have your gloves on, drape the resident if providing care in bed so that they're just not totally exposed. Use your wipes, one swipe, no scrubbing or reusing. Separate the labia and the skin folds carefully. Wash or wipe from front to back always. 1 wipe per swipe. Never go from back to front. Continue to wash and wipe the perineum, moving from the outside outward to the thighs. And then wipe away from the peri area. Don't wipe towards the peri area. This can bring bacteria back into that area. Continue to clean if soilage is noted on the wipe. Remove your gloves, wash your hands. Have the resident turn on their side and assist if needed, and clean the rectal area thoroughly, pulling skin folds apart to ensure no soilage is present. And always wipe away from the labia front to back. Remove your gloves, wash your hands. Put fresh clothes and Depends on the residents. Do not perform this task wearing soiled gloves. This is the one glove change that always gets us going from dirty to clean. So always change your gloves going dirty to clean. If the resident has assisted with peri-care, of course, have them wash their hands as needed, and then position the resident in their chair or in the bed. Reposition their covers, ensure the resident is comfortable, has their call light and bed control if needed, and then replace the drapes or blinds to the resident's preference. Wash your hands with soap and water, and remember to ask them if there's anything else they need before you go.
So I am Abby Groves. I am the Director of Business Development with Suncrest.
Jalisha, I am one of the Directors of Education at Suncrest Hospice.
So first off, I always want to say thank you for being such a great partner with Suncrest. You guys are a top-notch facility. You guys provide great care. Kelly asked us to come just to talk about, open up this discussion. This is very informal. So if you have experiences, you want to talk about something more in detail that we are talking about, please let us know. But today, Jalisha is going to talk about end-of-life cares and what kind of taking care of a hospice patient looks like. So I'm going to let Jalisha take it over.
Okay, like I said, I'm one of our Directors of Education. This is going to be a pretty informal presentation. If you have questions or want to dialogue as we go. Feel free to interrupt me. Just kind of going over some of those basic end-of-life cares. So providing end-of-life care for a hospice patient or anyone who's dying includes personal cares, emotional support, presence, and advocacy. So with personal cares, that can include repositioning, skin care, oral care, incontinence cares, and bed baths. Those are some of our most important things for a hospice patient. So with repositioning, it's important to continue to check and change the patient at regular intervals. A lot of times we see this every 2 hours. There might be a different policy, but just making sure that those patients are getting checked and changed, even if they're unresponsive and actively passing. That's important for a couple of reasons: skin integrity, comfort reasons, and to keep the blood flowing in their body. A lot of times you'll need assistance with repositioning and providing incontinence cares at this state because they're not able to actively participate in that repositioning any longer, so just get help if you need it. When repositioning, a lot of times you'll want to use pillows for support of the heels to avoid skin breakdown. If they're on their side, you might need a pillow between the knees to prevent that friction and breakdown. One thing with the repositioning and the floating of the heels is a lot of times you'll have a nurse say, so-and-so has skin breakdown, make sure their heels are floating. And so we'll see a pillow and those feet are right on top of the pillow. So that's not really floating the heel because you still have that pressure. So it's important to put the ankle on the pillow so the heel is over and it's actually floating in the air. When you're checking and changing, if you notice any skin changes or concerns, make sure they're reported to the nurse. And if you notice a patient is in pain, restless, anxious, whenever you're doing cares, report that to your nurse so that meds can be given about 30 minutes before you do those cares. With skin and oral care, a lot of people, as they're getting closer to dying, are going to dry out. Their skin's going to get dry, their mouth gets really dry. So just making sure we're applying lotion regularly. If you've got time, massage their legs, their feet, their back. We bring in the blue swabs to provide oral cares, keep their mouth moist, use chapstick as needed to kind of, a lot of times they have their mouth open, they've not been drinking, the medications can really be drying, so just making sure you're doing those things. If their eyes start to get dry and crusty, you can put a warm wet washcloth on them for comfort. And then a question that a lot of people ask is, if they're on oxygen and their nose gets dry, is how can we help with that if there's bleeding, things like that. It's just important to remember to use a water-based lubricant, no Vaseline or petroleum, or ask the nurse. They can oftentimes get an order for some saline spray. And then with emotional support and presence, this is just as important as physical cares. So providing that contact, holding their hand, that light massage. We talked a little bit, if you've got extra time and you're charting, sit with them, hold their hand, anything like that. Just provide presence, especially if they don't have loved ones here. Turn on some soft music that they like, speak softly and dim the lights just to provide that extra comfortable atmosphere. A lot of times loud stimuli can be too much for someone as they're passing. As long as the patient's able to communicate, make sure they're involved in their care, still allowing them to make their decisions as they're able. And even when they're not any longer, still speak to them, tell them what you're doing, explain things, talk about things that brought them interest before. They can always still hear you, and providing that presence as long as you can. This is primarily to the CNAs. I feel like they're always our eyes and ears in healthcare. I could never do my job without them. And a lot of times they've gotten to know that patient or resident better than we have. So they're always going to be their number one advocate outside of family, and sometimes more than family. So just making sure that you're communicating any concerns, changes, any of that kind of stuff to the nurse. Do it in a professional way. If you feel like you've talked to a nurse and you're not being heard and there's something concerning, talk to your leadership. You can involve the hospice team if necessary. Sometimes that's with family too. Just always make sure that you're using all your resources when those things happen. A lot of times, because you spend that more one-on-one time with them, you're going to notice the pain, anxiety, things before others. Additionally, you might also support the loved ones and make sure that things are prepared for when they come to visit. So keeping the patient's room cleaned up. I think you guys might, a lot of places do have like a snack and drink cart for families when they're here, and just making sure that area is comfortable. but we also need to provide privacy as necessary. A big thing that we see is when a patient's on hospice and families here 24 hours a day is we want to give them privacy. But what they notice, and a lot of times report back to hospice, is nobody came in and changed mom. Nobody came in to see if we needed anything. So while you're trying to be respectful and give that privacy, make sure you're still being present, asking to come in and change, asking to reposition. Most families are perfectly fine with taking a break, stepping out, and letting you do what you need to do. So just ask. Some of the frequently asked questions we get is whether or not you should feed the patient. So if you feel like they're at risk for choking, they're not able to swallow, they're not really responding to you, they've been sleeping a lot more, and you're just really not sure if you should be feeding them, ask the nurse. Occasionally there's nurses that will push to always feed. If you feel like that's an issue, you can always ask the hospice nurse when they're here to have that conversation too, or the opposite families a lot of times. Why aren't you feeding them? They need to eat, because they're really not understanding. So I always tell people, encourage, don't force when it comes to feeding. So if you feed somebody that's not hungry, you can cause stomach upset. If you feed somebody that's not really responsive, you always have that risk of choking and aspiration. So if you don't feel comfortable doing it, make sure you ask the nurse or whoever. Next is, should we get the patient out of bed? So if they're slumped over in a wheelchair all the time, not really responding, it's probably not appropriate to get them up any longer. But if they are able to get up comfortably, like we have the Broda chairs a lot, those help with those positions. But if they're not really responding, it's not necessary to get them up any longer. If we move or reposition the patient, will they die? This is a frequent concern. Staff will say, I don't want to turn so-and-so. If I put them on their left side is the most common concern, that person's going to die faster. So what I always tell people is, more than likely if they're on hospice and they're actively dying, they're going to die regardless. So you repositioning them isn't going to speed anything up. It still needs to be done for comfort purposes. So we can't lay somebody down and just leave them because we're afraid to turn them. With that, will they still need changed? Yes. So every cell in your body has fluid, and when the body starts to shut down, the kidneys are going to start pulling that fluid in. So even if they haven't drank for days, they're still going to have some urination until the kidneys start to shut down. And with that, at time of death, the body expels everything, so they do need those post-mortem cares to get cleaned up also of urine and bowel. And if that's something you're not comfortable with or haven't done before, our nurses and CNAs are always willing to help with that after death. And then if the patient is unresponsive, do medications still need to be given? And the answer to that is yes. So a lot of times we'll have a routine ordered medication, morphine, lorazepam, and the false conception is that if they're unresponsive, they're sleeping, they're comfortable. So we have to watch a lot of things, and as a nurse, you know that. Vital signs will indicate pain and anxiety, restlessness, things like that. And what we see is if somebody is unresponsive, sometimes nurses will hold those medications, and then we're playing catch up for the next 4 to 6 to 8 hours. So if there's ever a concern that we're giving too much or that we don't think those need to be given, just talk to the hospice nurse. Chelsea's great about having those discussions. So even if they're unresponsive, follow the schedule unless you have questions, and then we're free to talk about it. Any questions so far? I kind of ran through it really fast because I know you guys are busy. No. Any experiences or like conflicting things you've gone through with our patients or any end-of-life patients? No. Have you guys all worked with some dying patients? Yeah. Okay. The last group, we had some of both. So I just put a couple of quotes on here that made me kind of relate to this, that we cannot change the outcome, but we can affect the journey. So like I said, dignity, respect till the very end, like that should never go away. We should always treat them with respect and as a human and make sure that we're comforting them throughout. We are all just walking each other home. Let me hold your hand because someday someone will hold mine. So like I said, if you've got extra time and somebody is by themselves and they've been actively dying and family took a break, or they don't have family here, just providing that presence as your schedule allows, whether you're charting with them or you spend a few times before or after your shift. It's just nice for them to know that they're not there alone all the time. And then death is not the opposite of life, but a part of it. So everybody passes at some point in time, and just knowing that the way you're providing cares and changing them and repositioning them and doing those things at end of life, the natural process is going to occur whether we do those things or not. So making sure that they're taken care of and comfortable is important.
One powerful thing one of our nurses said in a meeting just recently is, you only get to die once. And that's super powerful if you think about it. And what an impact all of our jobs that we do, that we get to give those people. So by doing these things and helping them be comfortable, it's a pretty noble job.
In this job, I mean, especially in hospice, but I know, like I said, you guys have a lot of patients on hospice. We see a lot of death, and it can be very taxing. It can be draining. So just know that there's resources there. Like, our team is a great resource. We have chaplains and social workers that are here to support facility staff as well as families and the patients. So if you ever feel like you've had a tough one or there's a lot of death happening and you need somebody to talk to, our team is there.
And use us as a resource. You know, those tougher patients that we're teaming together, you need support. We're always available, no matter what shift you're working. You call us. We can sometimes just be a support over the phone. We can make visits. Doesn't matter if it's 2 in the afternoon or 2 in the morning. And our team's here for you guys. Any questions? Any comments? Kelly, do you have anything to add?
I don't think so. I really appreciate that we partner with Suncrest, because I think, you know, you're a great hospice. Other residents, families see the care that's given by your hospice, and that's why they choose you. But we are supposed to go above and beyond what you do. So we are not to withhold showers or baths because hospice is coming in. We're supposed to go above and beyond and take care of these people. They are our residents, and we are supposed to take care of them. And then hospice comes in and gives them extra care. So
It's definitely a team effort.
yeah.
It takes good teamwork. But yeah, like you said, you guys are still that primary care, and we're that extra layer to support everybody. So.
And you know them way better than us. So when our CNA, Sonia, comes in here, you have tips, and Chelsea's here. Share those with our team, because you guys know your residents way better than we'll ever know them. So we appreciate all you do.
Yeah. And there's a place in heaven for people that take care of those who are dying in a respectful way too. So, you know, it is, it's an honorable thing. So
Absolutely.
take good care of these people.
But reach out if you ever have questions, or we're always here for you.
Yeah.
I don't have a question, but I just want to say that everything you explain here is what we see, you know, here and, you know, on a daily basis, you know, as we deal with these people.
Yeah.
So your explanations, you know, has given us another insight of what we're supposed to do.
Yeah, those are the really common things that people get worried about, and it's hard because I was explaining in the last group that when you turn somebody like on their left side, yes, like hemodynamically, circulatory, the blood flow, it can accelerate things to some extent, but it's okay because it's going to happen. So why, instead of lingering things on, if it's making them more comfortable, if they're building up secretions and have that rattled breath, people call like the death rattle, put their head up, turn them on their side, all those repositioning things help so nature can just take its course however it's meant to.
Explain how the medication,
Morphine?
yeah.
So a lot of people, like I said, have those questions about like morphine and Ativan, or lorazepam is the other name for it, and how they're working and why we're giving them to somebody that's unresponsive. So morphine is a pain medication that also helps with breathing. So I explained that it's the physical comfort. And then Ativan, or lorazepam, is an anxiety medication, so it's more that mental, emotional comfort. So when you have somebody that has what we call like terminal restlessness, and they seem to try to be getting out of bed and kind of anxious and moaning and groaning and in pain and those things, When they get both of those medications, one relaxes the mind, one relaxes the body. And so a lot of people get nervous that when somebody's unresponsive and actively dying, that if they give another dose, that's it. Some people have that misconception that they are killing them by giving those medications. I've done this for almost 8 years now, and I've not seen somebody that's not ready to die from those medications. So you're just allowing them to pass a comfortable, peaceful death by giving those medications. You're not accelerating things. Nature can just take its course more easily than the body and the mind fighting itself while it's trying to happen. So I think sometimes that can be comforting to know.
I like that, how she explained that.
Yeah. So, yeah.
Well, thanks guys for coming. I know you're busy.
Yeah.
Trying to get out of here probably too.
Thank you.
Thanks for coming too.
Yes, you're welcome.
There's also general coding tips that apply to all self-care items. Residents with cognitive impairments and limitations may need physical and/or verbal assistance when completing an activity. If this assistance is offered for the safe completion of the activity, we need to code the level of assistance that was provided to perform that activity safely. If the resident does not attempt the activity and the helper does not complete the activity for the resident during the entire assessment period, we need to code with a activity not attempted code. An activity can be completed independently with or without assistive devices, and CMS does not provide an exhaustive list of assistive devices, but they do clarify that assistive devices do not include those devices that are restricted to use in the therapy sessions. The eating task is one task that is repeated many times during that meal. So if you can visualize a resident sitting with the meal placed before them, this is the task of bringing the food and or liquid to the mouth and swallowing. So if you can picture the resident eating through their meal, taking drinks during their meal, this is that task many times during that meal. If the resident requires assistance to complete the task for more than half of the meal, that would be considered more than half the effort. So again, if you can picture that meal before the resident and picture how much the resident ate of that meal, and then how much of what the resident ate was the resident able to do by themselves, and how much of what the resident ate did the staff assist with. And that can help you determine whether the helper was required for more than or less than half of the effort. We only consider help once the meal is placed before the resident, so it does not include how the resident gets to the table or how the meal gets to the resident, whether it's in the room or in the dining room. However, if the resident needs help with opening cartons or containers, this is considered setup assistance. The REI User's Manual also clarifies that this includes only the use of suitable utensils, but specifies that the resident may use their hands for finger foods. Eating does not include artificial routes for section GG, so it excludes any feeding by tube feeding, IV fluids for nutrition or hydration, TPN. So again, we're looking at only food and liquid that is placed when the meal is placed on the table before the resident. If the resident requires assistance such as supervision or cueing to swallow safely, so this is the part of the coding instructions where the resident has to bring the food or liquid to the mouth and swallow. So if the resident needs that assistance to swallow safely with cueing or supervision, we code based on the type and amount of assistance required for feeding and safe swallowing. If the resident can swallow safely without assistance, so this is going to be likely the majority of your residents who can complete the eating task and can swallow safely without those cues or supervision. In these cases, we exclude swallowing from the consideration with coding, so then we're looking only at the broader task of bringing food or liquid to the mouth. If the resident is taking only fluids by mouth, we code based on the ability to bring liquids to the mouth and swallow the liquid. For oral hygiene, there's a few items to consider. So first, for residents' natural teeth, this is the use of suitable items to clean the teeth and rinse the teeth. For dentures, there are two main tasks: the ability to insert and or remove the dentures into and from the mouth, and the management of soaking and rinsing. Now, you may have a combination of both of these. You may have residents that have either full upper or lower dentures and natural teeth, or partial dentures with natural teeth. Now, you may also have residents who are edentulous, where they have no natural teeth. For these residents, we are to code based on the type and amount of assistance to clean the resident's gums. Additional coding tips tells us that setup includes gathering the equipment at the sink or the bedside and applying toothpaste to the toothbrush. And so when you think about the actual task is the cleaning of the teeth, the rinsing or the cleaning of the dentures and the rinsing. When you have the equipment set up, that is part of setup, and when you are cleaning up, that's part of the cleanup. And so anything that happens before or after that actual task of cleaning and rinsing would be setup and cleanup help only. And then we're actually looking at the task for the ability to clean and rinse. Toilet hygiene takes place before and after the use of toilet, commode, bedpan, or urinal. And there's three main tasks involved. The first is managing your undergarments, clothes, incontinence products before elimination. And then after elimination, the perineal cleansing. And the third is managing undergarments, adjusting clothes, and incontinent products after elimination. So you can pretty much break this into the three tasks of clothes down to allow for elimination. The elimination occurs, which is not part of the task, the perineal cleansing, and then replacing of those clothes and undergarments. If a resident has an ostomy, we do include wiping of the opening, but does not include managing the equipment. If a resident has an indwelling catheter, this includes a perineal hygiene to the catheter site, but does not include managing the equipment. So as we talk through this, if a resident has a catheter and the staff go in and they complete all the perineal hygiene, this would be where the resident is dependent on that hygiene task during that episode of care. There are also some coding tips. If a resident does not usually use undergarments, document the resident's need for assistance to manage lower body clothing and perineal hygiene. If the resident has an indwelling urinary catheter and has bowel movements, document toilet hygiene based on the amount of assistance needed by the resident before and after moving bowels. When a resident requires different levels of assistance after avoiding versus having a bowel movement, code based on the type and amount of assistance required to complete the entire activity. For shower and bathe self, there are three main tasks. The first is the resident's ability to wash the face, upper body, lower body, perineal area, and the feet. And the second task is the ability to rinse all of these areas. And the third, the ability to dry all of these areas. So when you look at the shower or bathing activity, we're actually looking at three different tasks and then a lot of different body parts within each of those tasks. So the resident may be able to wash some parts of the body and need help or assistance for, say, the lower body and feet, or they may need help just with rinsing or just with drying. So we have to look at all of those different tasks as well as all of the areas within each of those tasks to help determine whether the helper does more or less than half the effort. There are also several tips for shower bathe self. The first is that we do not include washing, rinsing, or drying of the resident's back or hair. So you can kind of just think about the back and the hair as excluded body parts. We don't count any of the aspects that are included for washing, drying, rinsing those two items. We also do not include the transferring in or out of the tub or shower. So it doesn't matter how they get there or how they get back, just once they're there, how do they wash, rinse, and dry? The shower or bathe self can take place in a shower, in a bath, at the sink, in bed, or seated on a tub bench. If the resident is able to bathe themselves after the helper sets up materials, then that would be setup or cleanup assistance only. Again, keeping in mind that anything happens before or after the actual activity is setup and cleanup. So as long as they're set up and then they can do the washing, rinsing, and drying themselves, it would be setup or cleanup assistance only. If the resident cannot bathe their entire body because of a medical condition, such as a cast, then we code based on the amount of assistance needed to complete the activity. So if you consider a resident who may need a cast covered before they go in to complete the bathing tasks, that would be setup help only. If the resident actually needs the staff to help wash part of the body, say they can't reach their lower legs because of a cast on their upper arm, then that would be part of the bathing task and coded accordingly. Now we'll move into the dressing items, and the first dressing item is upper body dressing, and we can look at this at two distinct tasks: the resident's ability to dress above the waist and the resident's ability to undress above the waist. And so as you may realize that some of these tasks will only happen at certain times in the day, so the resident may take off their night clothes in the morning and put on their day clothes during that same task, and then dressing might not happen again until that evening when they remove their day clothes and put on their night clothes. The helper assistance with buttons or fasteners is considered touching assistance. So if the resident's able to put on their blouse and they only need staff to help with the buttons, that would be touching assist. Upper body dressing does include a bra, undershirt, t-shirt, button-down shirt, pullover shirt, dresses, sweatshirts, sweaters, nightgowns, but not a hospital gown. It does include pajama tops, again, but not the actual hospital gown. Hospital gowns are not considered in the dressing task, and upper body dressing cannot be assessed solely on donning or doffing the hospital gown. So if the resident only wears a hospital gown during that entire shift and that gown is changed, that would be an activity that did not occur for upper body dressing. Now, another important consideration when it comes to dressing is this also includes upper body braces or devices. So any type of splint, brace, prosthetic, support shrinker stock that is used on the upper body, that is considered part of upper body dressing. If a resident dresses self but the helper retrieves or puts away clothing, this is setup or cleanup assistance only. Again, that's all things that happen before or after the actual task of dressing or undressing. Next is lower body dressing, and we have two very similar tasks: the ability to dress below the waist and the ability to undress below the waist. But this does not include footwear. It does include the underwear, incontinent briefs, slacks, shorts, capris, pants, pajama bottoms, and skirts. And keeping in mind that, again, if you help with buttons or fasteners only, that is touching assistance. When we talk about lower body dressing, this again includes any of those lower body braces or devices, such as a knee brace, elastic bandages, stump or sock shrinker, lower limb prosthetics. And if a resident dresses himself, but the helper is just retrieving or putting away the clothing, that is considered setup or cleanup assistance only. So as I mentioned, the putting on and taking off of footwear is a separate task. And here we have two subtasks or tasks within this item, and that's a resident's ability to put on socks and shoes or other appropriate footwear for safe mobility, and the resident's ability to take off the socks and shoes. So we're really looking at on and off as well as both socks and shoes. As we mentioned before, any help with buttons or fasteners is considered touching assistance. And when we're coding footwear, in addition to socks and shoes, we also include boots, running shoes, braces or devices to the feet, which may include ankle or foot orthotics, elastic bandages, foot orthotics, orthopedic walking boots, and compression stockings. Compression stockings are considered footwear because they are donned and doffed over the foot. If the helper retrieves or puts away the footwear, this is setup or cleanup assistance. For a resident with a bilateral lower extremity amputation with or without the use of prosthetics, the activity of putting on and taking off footwear may not occur. For example, the resident's socks and shoes may be attached to the prosthetic associated with the upper or lower leg prosthetic. For residents with a single lower extremity amputation with or without the use of prosthetic, the activity of putting on and taking off footwear could apply to the intact limb or to both, the limb with the prosthetics, and the intact limb. Personal hygiene is the next item, and this is a little different for the types of tasks. So here we actually have variable tasks because the personal hygiene that is completed is going to be dependent on a lot of the resident's preferences. So if the resident has hair, there'd be the combing of the hair, but a resident may have opted to shave the head or be naturally bald and not have hair to comb. Shaving, there may be residents who shave daily who need just a little trim, or those who have a full beard and mustache and do not need shaving. Applying makeup would be dependent on the resident's preferences, and then of course washing and drying the face and hands would apply to all residents. One of the coding tips is that personal hygiene does not include baths, showers, or oral hygiene. Before we move on to the mobility items, we're going to look at the decision tree for the performance scale and do some check your knowledge practices, and then we'll get on to the mobility items. The decision tree is very helpful when you're looking at per episode documentation for supporting the level of care during that episode. The decision tree is not as useful when you're talking about determining usual performance for the resident during that assessment period. For the decision tree, we start at the top, and we have to ask a question: does the resident complete the activity with or without assistive devices by him or herself with no assistance? And this includes no physical, verbal, nonverbal cueing, setup, or cleanup assistance. If yes, we would document that level of care as independent. If no, we ask the next question: does the resident need only setup and cleanup assistance from one helper? If this is yes, we document as setup and cleanup assistance only. If no, the next question is, does the resident need only verbal or nonverbal cueing or steadying, touching, or contact guard assistance from one helper? If yes, document as supervision or touching assist. If no, we ask the next question: does the resident need physical assistance, for example, lifting or trunk support, from one helper providing less than half the effort? So again, this is weight bearing with one helper, less than half the effort. If yes, this is partial or moderate assistance. If no, we go on to the next question: does the resident need physical assistance, for example, lifting or trunk support, from one helper, with the helper providing more than half the effort? If yes, substantial or maximal assist. If no, we ask the final question: does the helper provide all of the effort to complete the activity, or is the assistance of two or more helpers required? If yes, we would document as dependent. All right, for mobility items, we also have some general coding tips, and this first one is one that we've talked about before. Residents with cognitive impairments and limitations, they may need physical or verbal assistance to safely complete that activity, and even if that assistance is due to their cognition, we do reflect the amount of assistance needed to safely perform the activity. An activity can be completed independently with or without the assistive device, and CMS does not give us an exhaustive list of all those devices that can be used. And we do not use any of the devices that are restricted to the therapy sessions, such as the parallel bars. So roll left and right is a bed mobility task, and essentially what we're looking here is a resident who's laying on their back in the bed and their ability to roll from the back to the left side, back into their back, and to the right side. And these can be in any order to include both left and right and returning to lie on their back. The resident can use assistive devices, side rails, and trapeze. And if a resident does not sleep in a bed, then the clinicians should assess bed mobility activities in their alternative furniture, such as a recliner. The sit to line task is really one task with two parts, depending on how it is completed. Essentially, it's the ability to move from sitting on the side of the bed to lying flat on the bed. So here, if you picture a resident sitting on the side of the bed, this includes lowering the upper body into the bed and lifting the legs into the bed. And the reason we separate this out is because a resident may be able to help with part 1 or part 2, or they might be able to do this all in one motion, or they need 1 or 2 helpers to do both. So a resident may be able to hold onto a trapeze and lower the upper body into the bed while the staff member lifts the legs into the bed. Or you may need 2 helpers, one managing the upper body and one lifting the legs into the bed. So really looking at that movement that could be one smooth movement or could be broken down into upper body movement to lay back in the bed and lifting those feet into the bed. This item does not include repositioning or boosting up in bed, but does apply to a recliner if the resident is using that as an alternative sleep furniture. Lying to sitting on the side of the bed is essentially the opposite movement of our last task, the sitting to lying. Here we have a resident who starts by lying on their back in the bed and moves to sitting on the side of the bed. Here we have a motion that could be one solid motion done in tandem, or we could have 2 distinct parts where we have the rising of the body, upper body from the bed and moving the legs over the side of the bed without back support. So if you consider again a resident who may use a trapeze, they may be able to rise the upper body from the bed while the staff member moves the legs over the side of the bed and then helps to position them to a sitting on the side of the bed position without back support. This item also does not include repositioning or boosting up in bed. However, if the resident uses a recliner or other alternative sleep furniture, that should be considered. The next activity is sit to stand, and this is one task where the resident comes to a standing position from any seated position on any surface. Now, a couple coding tips here. If a stand assist lift is used, where the resident's actually standing in the lift, and 2 helpers are needed for safety, that would be considered dependent because it's a 2-person help for the resident's safety. However, if a full body mechanical lift is used, which essentially transfers the resident from one seated position to another seated position and the resident's never actually standing, then the sit to stand would be coded with the appropriate activity not attempted code. We would use 05 setup or cleanup assistance only if the helper just had to retrieve equipment so that that task can be performed, such as getting the resident positioned with their walker so they can move from a sitting position to a standing position. The chair or bed to chair transfer is 2 main tasks. It begins with the resident sitting in a chair or wheelchair or sitting upright on the edge of the bed, and ends with the ability to return to a sitting position in a chair, wheelchair, or upright on the edge of the bed. So essentially we're moving from a seated position to a different seated position. And for coding tips, it does clarify that this could include a stand pivot, squat pivot, slide board, standing lift, or other mechanical lift. If a mechanical lift is used to assist in a chair or bed to chair transfer with 2 helpers, this is considered dependent because 2 helpers were needed for that safe transfer. When possible, the transfer should be assessed in an environment situation in which there's only a few steps between the 2 transfers. So not the resident leaving their chair in their room and walking 150 feet to sit in the dining room. This is looking for a transfer that is within a few steps whenever possible. The activity of toilet transfer has 2 main tasks. The first is the ability to get on the toilet or commode, and the second is the ability to get off the toilet or commode. Now, a coding tip here is that this only applies to the toilet or commode. It does not apply to urinals, bedpans, or other elimination devices. We are simply looking at the physical ability to get on the toilet or commode and off. We also do not consider toilet hygiene tasks, so any of the clothes management or perineal hygiene, that's all considered under toilet hygiene, which we covered in the self-care items. The next item, tub or shower transfer, can be broken down into 2 tasks: the ability to get into the tub or shower and the ability to get out of the tub or shower. Do not include washing, rinsing, drying, or any other bathing activities in this item. The activity of card transfer looks at two main tasks: the resident's ability to transfer into the passenger side of a car or van, and the resident's ability to transfer out of the passenger side of a car or van. Now, as you're completing the documentation for this activity, if a resident's going out to an appointment with a family member and transfers into that passenger side of the car, that might happen on, say, the day shift. But if the resident does not return until evening, the ability to transfer out of the car would be documented by the evening shift. So this does not have to happen at the exact time, but again, during that course of that transfer in and transfer out, we would be documenting the resident's ability during that task. Some of the coding tips is that a car transfer should never be attempted in a staff member's personal vehicle. You can use indoor car simulators if your facility is equipped with one. The car transfer does not include transfer into the driver's seat or the ability to open and close the door or fasten the seatbelt. So it's simply getting into that passenger side of the car or out of the passenger side of the car. If a resident remains in the wheelchair and does not transfer in and out of the car, so say it's a wheelchair van where the wheelchair is lifted into the van, a wheelchair lift and then secured, that is not considered a car transfer. Either it has to be a transfer into the passenger side of the car. We also do not consider any assistive devices that are used to get to that car transfer. So if the resident needs a walker or wheelchair to get to the car, we do not consider those assistive devices or that amount of assistance needed to get to the car, only the amount of assistance needed for the actual transfer in and out of the car. There are several coding tips that apply only to the walking items. The REI User's Manual clarifies that the assessment of the walking activities starts with a resident in a standing position, which means we're not including the level of assistance needing to move from that sit to standing position, which is coded or documented as sit to stand. A walking activity cannot be completed without some level of resident participation, which means the staff cannot walk for the resident. So when it comes to the level of assistance, a helper cannot complete a walking activity for a resident. So the only time walking can be coded as dependent is when two helpers are needed to safely complete that activity. But say if a resident cannot walk 150 feet, they can only walk, say, 25 feet, then the helper cannot walk the rest of that distance for the resident. So that would be an activity not occurred for that activity. During a walking activity, the resident is allowed to take a brief standing rest break. But if the resident needs to sit down during that walking activity, it should be coded with the appropriate activity not attempted code. Clinicians can use clinical judgment to determine how the actual resident assessment of walking is conducted. If the clinician chooses to combine the assessment of multiple walking activities, the clinician should use their judgment to determine the type and amount of assistance needed for each individual activity. So what that means is that when a resident is walking, say 10 feet, and then if they continue on to walk not only that 10 feet, but walk 50 feet with 2 turns, the clinician would need to use their judgment to see how much assistance they needed during those first 10 feet versus the amount of assistance they needed for 50 feet with 2 turns. Also, to use clinical judgment when assessing activities that overlap or occur sequentially to determine the type and amount of assistance for each individual activity. So again, you could be helping a resident down to the therapy gym, and during that activity, they do walk the 50 feet with 2 turns, and it can be assessed with your clinical judgment based on that activity. Another coding tip is that the walking activities do not need to occur in one session. So for example, if a resident is very fatigued after walking 50 feet with 2 turns, you do not have to immediately attempt 150 feet. You can have a break and a rest period before 150 feet is attempted. So let's take a closer look at each of these walking items. The first is walk 10 feet, and we consider this a gateway question because there's a skip pattern. If the resident cannot walk 10 feet, the remaining walking items are skipped. Walk 10 feet is essentially one task, and it's once the resident is standing, the ability to walk 10 feet in a corridor or similar space. Now, we cannot consider the resident's mobility while using parallel bars or other assistive devices that are restricted to that therapy gym. And we do not consider support needed to assist the resident to that standing position. Again, considering that sit to standing is documented separately, this is only once standing, the ability to walk 10 feet. The activity of walking 50 feet with 2 turns is essentially 3 tasks. The first is once standing, the ability to walk at least 50 feet, and then making a first turn 90 degrees in either direction and a second turn 90 degrees in either direction. The turns can be in the same direction and they can occur at any time during that activity. We just have to have those 3 tasks completed within that activity. So walking a total of 50 feet and having 2 90-degree turns. This can be part of other activity. Like we mentioned earlier, the resident can come out of the room, take a 90-degree turn down the hallway, and walk another 45 feet to the activity room, makes another 90-degree and 10 feet into the activity room. And we would have our 50 feet or more of walking plus our 2 90-degree turns. And again, this is only one standing, so we do not consider the support to move from that seated position to a standing position. The activity of walking 150 feet is essentially that one task, the ability to ambulate at least 150 feet. One of the coding tips, like we've had with the other walking items, is this again is only once in a standing position, so we do not consider that support moving from a seated position to a standing position. Another coding tip we have is that if the environment does not accommodate for walking 150 feet without turns, but the resident is able to demonstrate the ability to safely walk 150 feet with turns, we can use that distance in code using the 6-point scale. The activity of walking 10 feet on uneven surfaces is one task, and that's again the resident's ability to walk 10 feet on uneven or sloping surfaces. This can be indoors or out, such as on turf or gravel. Some of the coding tips here is that again, we're only looking at once the resident standing, so we do not count the moving from a seated position to a standing position. Once that activity starts, we're looking at what is the surface, and so this is based on clinical judgment to determine whether that surface is uneven, sloping, or meets the qualifications of turf or gravel. We also have some general coding tips for the step items. The first is that completing the stair activities indicates that a resident goes up or down stairs by any safe means, with or without an assistive device. So this would include using a railing or even a stair lift, and with or without some level of assistance. Getting to and from the stairs is not included when we code the curb or the step activities. Ascending and descending stairs does not have to occur sequentially, so during the same session. And if the assessment is going upstairs and then downstairs sequentially, the resident may take a standing or seated rest break before ascending and descending the 4 steps or the 12 steps. If a resident requires a helper to provide total assistance, for example, the resident requires total assistance to move up and down over one curb, say they're going out to the wheelchair van and they need help navigating over that curb. If that one step, that curb needs navigated even in the wheelchair, that would be coded as dependent if the helper does all the effort. A resident who uses a wheelchair may also be assessed going up and down the stairs. This includes one step or a curb. And again, this can be using that stair lift or other methods as long as the resident is safe. A few more coding tips here. If the stairs were not attempted because of a physician prescribed restriction, we would use the activity not attempted code as 88, that we did not attempt due to that medical condition or safety concern. If a resident is going up and down a curb and a step and their performance varies depending on whether it is a step or a curb, we do code based on which required the most assistance. And the final coding tip is that if the residence environment does not have 12 steps, the combination of going up and down 4 stairs 3 times consecutively in a safe manner would meet that definition and be able to be recorded, documented, and coded as the 12 steps. So let's take a look at each of these step items individually. The first one we have is one step or curb. And this essentially is two tasks: the resident's ability to go up a curb or step, and the resident's ability to go down a curb or step. So we're looking at both up and down that one step or curb. And this can be with or without a railing and or assistive device. 4 steps, very similarly, we have the ability to go up 4 steps and down 4 steps with or without a railing or assistive device. 12 steps is a resident's ability to go up 12 steps or down 12 steps, and again, with or without the railing or assistive device. And as we mentioned in the general coding tips, if you only have, say, 4 steps in your therapy gym, you can do the 4 steps consecutively, 3 times consecutively to meet the requirement of the 12 steps. The next activity is picking up an object. This is one task where we're measuring the resident's ability to bend or stoop from a standing position to pick up a small object, such as a spoon, from the floor. Some of the coding tips for this item include: if a resident requires a helper to retrieve a device, such as a long-handled reacher, then that is setup assistance. It also must be assessed while the resident is in a standing position. If the resident is unable to stand, this item should be coded as not attempted. Assistive devices and adaptive equipment can be used, so this can be a cane to support balance while picking up an item, or even the reacher to pick up the object off the floor. And that brings us to the wheelchair items, which are only assessed if a resident uses a wheelchair. The first item is wheel 50 feet with 2 turns. Essentially, this is broken down into 3 tasks: the resident's ability to wheel 50 feet, and the ability to make the first 90-degree turn in either direction, and the second 90-degree turn in either direction. Some of the coding tips for wheel 50 feet with 2 turns is that these 90-degree turns can be in the same or opposite directions. We also only start assessing this, or the direct care staff to document on what occurred during that episode, once the resident is seated in the wheelchair or in the scooter. For these wheelchair items, it's also important to document if the resident's not able to perform the entire distance themselves, and so the staff propels the resident the rest of the way. Document if the helper was needed to perform more or less than half of that task, so we know how that would be represented during that episode of care. The next item is wheel 150 feet, and this is the resident's ability to wheel 150 feet in a corridor or similar space. Some of the coding tips here: if the resident can self-propel part of the distance but not the total distance and needs assistance from a helper to complete that distance, to determine the amount of assist provided for the entire activity. For wheelchair items, if the resident is not able to perform the entire distance specified, again, the helper can complete the rest of that distance. If the environment does not accommodate 150 feet without turns, if the resident is able to demonstrate wheeling 150 feet with turns without jeopardizing safety, we would code based on that performance. When a resident is unable to wheel the entire distance, again, this activity can be completed by a helper. All right, so before we go into our knowledge checks, I did want to bring back up that decision tree for the performance scale. As we go through our knowledge checks, we're going to be looking at how, with each of those mobility tasks, how much assistance was needed during that episode of care. All right, let's move into our knowledge checks.